In this lecture, we'll discuss hypokalemia, including its potential causes and complications, as well as its EKG features. Hypokalemia, or low serum potassium levels, can start to cause complications around 3 millimolars per liter and below. Hypokalemia causes myocardial hyperexcitability with the potential to develop reentrant arrhythmias. Some causes include alcoholism, malnutrition, diarrhea, vomiting, primary and secondary aldosteronism, glucose infusion, diuretics, corticosteroids, insulin, among many others. So what can we see on the EKG? Well, first, T waves tend to become wider and lower in amplitude. T wave inversion may also occur if hypokalemia is severe, okay? So you can see this is pretty much the opposite changes we saw in hyperkalemia. So notice here's our potassium level. We're going down, so we're going towards the negative. So our T wave amplitude starts to go down, okay? And our duration tends to get wider, so we get wider T waves. Okay, so those are two early signs that we tend to see. Next, we see ST depression that can occur. Okay, and if the T wave inversion is present, it can mimic myocardial ischemia. So again, here's our T wave, okay, and we can see our T wave, which it's doing is flattening, so it's coming down, it's getting wider. Now we're starting to see ST depression, which is this here. Okay, remember here's our PR segment. Notice it's below baseline, so we have ST depression, where we measure from our J point. Okay, and we said if you have ST depression plus T wave inversion, it may actually mimic ischemia. Okay, so that's if T wave inversion is present. So in here we don't have that, but if you were to see that, you can see how it could mimic ischemia. Now the P wave amplitude and duration may increase, and so may the PR interval. Okay, so P wave duration. Here's our P wave, so duration getting wider, as well as our PR interval, which is from the beginning of our P wave up until our QRS complex. You can see that getting wider as well here. Okay, so you can, those are two things you can see, as well as the P wave amplitude getting taller, going up. Okay, so our P wave getting increasing in amplitude in that case. Now U waves may also manifest and are often most prominent in the precordial leads, especially leads V2 and V3. If hypokalemia becomes so severe, the U wave may even become larger than the T wave, okay? So here's our U wave, which are commonly characteristic, and most people think of hypokalemia, they usually tend to associate it with these U waves, okay? So if hypokalemia is so severe, these U waves can increase in amplitude and become greater than our T waves, okay? You can see that here. The U wave amplitude becoming greater than that of the T waves at great lower potassium levels, okay? And remember, V2 and V3, we tend to see the most prominent U waves there. Now, the QT interval may also appear prolonged due to fusion of the T and U waves, which is called TU fusion. And this leads to a long QU interval, okay? So we said U waves can appear during hypokalemia, and because of that we can have TU fusion where these T waves and the U waves fuse, and because of that we can have a prolonged QU interval from the beginning of our Q wave to the end of our U wave. So that's called a QU interval, okay? And make sure you're aware that's from TU fusion and not a prolonged T wave. Remember, we have our U wave that's becoming now fused with our T wave and making that QT interval appear prolonged, okay? So this is a long QU interval that we call it. Now, a few last clinical points to be aware of are that hypokalemia can potentiate the proarrhythmic effects of digoxin as it competes for spots on that sodium channel ATPase, which digoxin targets. In addition, it can cause monomorphic VTAC as well as acquired long QT syndrome, which may predispose the patient to torsades de pointes, a form of polymorphic ventricular tachycardia. You also want to make sure to check magnesium levels because hypokalemia is often associated with hypomagnesemia, which increases the risk of malignant ventricular arrhythmias. All right, let's review what we discussed before we end here. So hypokalemia is when we have low serum potassium levels. This results and leads to myocardial hyperexcitability with the potential to develop these reentrant arrhythmias, okay? We said to check the magnesium levels because you tend to see these associated with each other. Okay. Now causes, we mentioned alcoholism, malnutrition, diarrhea, vomiting, among many others, and you can see them listed here. In terms of the EKG features, remember the increase in the T wave duration and the decrease in T wave amplitude, as we saw it going down, is a common early feature. The ST depression is something we can see, and if there's T wave inversion present, that can actually mimic myocardial ischemia. We can also see an increase in the P wave amplitude as well as the duration as it gets prolonged, and you can possibly see an increase in the PR interval. Okay, now the U waves are a common thing that most people associate hypokalemia with, and these are most prominent in the precordial leads, especially V2 and V3. If severe hypokalemia, we said that the U waves may actually get even larger than our T waves, okay, as you saw here, the U wave amplitude exceeding that of the T wave. We could say there's an apparent long QT interval, but that's from that TU fusion. We have our T and the U wave fusing together, so it makes it appear like we have a long QT interval, but that's more of a prolonged or a long QU interval, okay? We also said arrhythmias can develop, monomorphic or polymorphic VTAC, such as torsades, secondary to acquired long QT syndrome that can develop. Well, that's the end of this lecture. We discussed hypokalemia, including its potential causes and complications, as well as its EKG features. I hope you learned something.